Hello, everybody, dear audience everywhere around the world. Good morning, good afternoon, or maybe good evening. Thank you all for joining the ISPD debate. The first trimester anomaly scan should be moved to the first trimester. My name is Monique Haak. I'm a fetal medicine specialist in the Leiden University Medical Center. The ISPD debates are always my favorite part of the ISPD conferences, although it is not so aggressive as this photo suggests, as it is an excellent way to update your knowledge on a subject of the statement. And the super plus bonus is that the subject that is discussed from opposite perspectives by experts in the field. So it is not just an update, but a critical appraisal from two different angles. The subject of the current debate is the first trimester anomaly scan. And I have a disclosure to declare. I myself am a big fan of first trimester ultrasound. These two examples in this slide show the power of ultrasound in early gestation. The details you can get enabling first trimester findings we would never have imagined to see 15 years ago. But in the preparation of this debate, I was thinking what arguments the debaters would bring to the floor. And we can think of many different things. Do we as doctors have enough experience to take this step to move it to the first trimester? And what kind of pathology will come into our clinics? And will there be new findings of which we do not know what the outcome will be at this early, to predict it from this early gestation? And at the economical side, do we have enough resources to offer this to every pregnant woman? In the clip of in the left side of the slide, it is easy. You think this diagnosis should not wait until 19 weeks. But at the right side, you can be a bit more critical. Here, a right aortic arch is depicted. Do the parents of this fetus really benefit from a diagnosis 7 weeks earlier than they otherwise would have been gotten? These arguments create a difficult balance, and all the arguments will be brought to the floor by two experts in the field. Dr. Matt Grace will argue against. He is a maternal fetal medicine specialist and associate professor in the Vanderbilt University Medical Center in Nashville. He serves as the program director for the MFM Fellowship, and he is the medical director of the unit of prenatal diagnosis at Vanderbilt. His clinical and research interests are in prenatal diagnosis, fetal imaging, complex obstetrics, and fetal therapy. On the right side, you see the pro-debater, César Meller. He works at the hospital Italiano, where he is the chief of obstetrics. And this is situated in the beautiful city of Buenos Aires in Argentina. He is also the president of the Argentine Society for Prenatal Diagnosis and Treatment. And both are competitive. At the left side, you see Dr. Grace. He is a good fisher, bringing home very big fishes, and he's a winner on that part. On the right side, you see a fanatic tennis player and rock star in dancing on the podium. So these two experts will argue against and pro. And the ISPD debates always start with a voting. And I will ask you to scan with your phone or another device the QR code that the ISPD team will depict on the screen right now. And there will be a bit of delay. I will stop sharing. The QR code is quite tiny, so you should go close to your screen to do the poll. And first we see some people who are pro the argument the anomaly scan should be moved to the first trimester. And I hope that we will get a little bit more votings. Is it economical? Can we do that everywhere in the world? Does it have advantages or does it also have disadvantages? Please vote. Yeah, now there are also some people who are against. And we have to be a bit patient because we know that there is a little bit of delay. And now we're going to see that things are a little bit changing. But the majority is still pro. So Matt, I think you have a big task because it is ISPD tradition that the debater that has shown the biggest change, so it's not the majority or that wins, but the person that creates the biggest change. And Pete, I think we are closing the poll now. Yeah, exactly. I see instructions that we close the poll. It is 54 against 46. And I will give the floor to Dr. Meller, who is arguing the pro. Feel welcome, Dr. Meller. The floor is yours.
Thank you, Monique, and thank you for this wonderful introduction. So, I do believe that the anomaly scan should be moved to the first trimester. Time is really important for all of us, isn't it? I think this debate is not whether we should replace the second trimester scan, because we shouldn't. I think this debate is whether families should wait until 20 weeks for their first anatomical assessment, especially when we already bring them for the 12-week nuchal translucency scan. So over the last decades, we've been shifting the diagnosis of congenital malformations from the postnatal period to prenatal diagnosis, and second trimester anomaly scan became the gold standard. Now in 2026, I believe the anomaly screening should start in the first trimester. Some questions. Is timing important? How does it work? Which is the screening performance? And are we going to increase parental anxiety by introducing a first trimester anomaly scan? Let's start with the easiest one. Is timing important? This is the part of the experience published by the Dutch healthcare system with Monique, our moderator. They introduced a first trimester anomaly screening program, and they showed us in different papers the different part of their experience. In this one, regarding psychological impact, they showed that early termination of pregnancy is associated with a lower psychological impact compared to late termination of pregnancy, perhaps because of less intense fetal attachment or other reasons like more time for reproductive decision-making, but being able to do an early termination of pregnancy is associated with a lower psychological impact. Second, refer to talking about timing of referral to maximize opportunities for optimal pregnancy care. Distances. Problem when we have to think in fetal therapies, for example, where there are some time windows that need to be addressed. We had a patient with spina bifida that was diagnosed at 20 weeks, and she was 27 weeks and still waiting for the healthcare company to approve the surgery. And third, in obesity, a risk factor for anomalies and for incomplete second trimester anatomy scan, a first trimester anatomy scan with an endovaginal option plus a second trimester anatomy scan is associated with improved completion rates and greater patient satisfaction. So I believe that time is important. Second, how does it work? How does the first trimester anomaly scan work? We know that there are some anomalies that should always be detected, like this anencephaly, others that are sometimes detected, for example, the spina bifida, and others that are rarely detected because they usually develop later on. So, detection rate in the first trimester is pretty good for measure congenital anomalies between 80 to 90%, but it's around 30% talking in general. So we have to acknowledge that the detection rate in the first trimester is far from perfect. And therefore, before the first trimester scan, we need a proper counseling. But that's exactly the same that happens before the second trimester scan, because how does it work? How does the second trimester anomaly scan, our gold standard, work? We have this Cochrane review about diagnostic accuracy of ultrasound screening for fetal structural abnormalities during the first and second trimester. And we can see that as a single stage screening, the second trimester, it's not perfect too. It has a detection rate of around 50% for a false positive rate of 0.2%. So detection rate in the second trimester is also far from perfect. What we can do to improve the performance is the two-step screening, integrating first and second trimester. And we can get a detection rate of around 80% for a false positive rate of 0.1%. Of course, there are some limitations. It can be argued that this is only possible in expert centers, but anti-screening, the second trimester anomaly scan, NIPT also started in expert centers and then expanded progressively. And actually, there's a national implementation already happening in the Netherlands. So even though I believe that implementation is a challenge, I also believe that it shouldn't be a reason to delay progress. So some facts. First trimester cannot replace second trimester. I agree. Some anomalies develop later. We've seen that. And we still need later scans. I also agree. That's why I think the question is not which single scan is best. The question is when screening should begin. And that's why I bring the ISPD Pioneer Award recipient, Professor Kypros Nikolaidis, and his concept of inverting the pyramid of care, focusing on stratification of care at 12 weeks, and then reassessing the risk at 20 weeks and 35, 36 weeks. We accepted evolution in technique, in equipment, and expertise for first trimester screening for trisomy 21. We accepted the NIPT revolution. Why are we reluctant to accept evolution in first trimester anatomy? We have better ultrasound machines. We have Doppler and transvaginal scan. We gained a lot of experience, and we have something fundamental that it's the concept of standardization. We have international guidelines that state that changing from a protocol based on minimum requirements to a more extensive best practice systematic review will increase our detection rate. Coming back to the Dutch experience, this IMITAS study, they compared what happened in blue before introducing the first trimester anomaly scan and in orange after the introduction of the program. And they describe what happened in the FTMA. This is the first trimester measure anomalies that should always be detected. In the often detectable group, spina bifida, some CHD, and the rest of the anomalies in the other group. In the FTMA, those that should always be detected, they found a marginal increase of the detection rate. And when they analyzed the reasons of those undetected cases, of course, the vast majority were in the rarely detectable group or the often detectable group, but among those FTMA, those that should always be detected, they found that there were missing mandatory planes and acquisition of suboptimal planes. That is related, the improvements are expected when completing the standardized protocol. Again, the importance of standardization. And again, the importance of standardization will be with the AI. Artificial intelligence technology has been advancing in the second, but especially in the first trimester ultrasound, enabling standard imaging acquisition and structural analysis. And then in the other two groups, in the often detectable anomalies and the other anomalies, they showed a significant increase in detection rate, which shows us that a dedicated program with standardization and training really may be associated with a performance. But are we going to increase parental anxiety by introducing this? If we have 100,000 pregnant women, we saw that we have already seen that there are going to be some congenital anomalies, but the vast majority will have normal anatomy. If we introduce a first trimester anomaly scan, we will have this normal baby, some abnormal scan, false positive results, and we are going to share parental anxiety babies that are actually not. That's true. But the same happens in the second trimester anomaly. There are also positive results. And we are used to coming across positive results, for example, for the nuchal fluorescency, for the screening from trisomy 21, 3 to 5%, the 90.1%. The important thing when we have a positive screening is to know the steps to follow. In this case, proper counseling, a detailed scan, and a diagnostic test. The same happens in the first course of the trimester in anomaly. To have a positive screening, what you need to do is proper counseling and a proper diagnostic workup, which probably a diagnostic scan and eventually severe or abnormal. So it's also important to mention that the vast majority of the babies that have a normal anatomy will have a normal scan. And we are sure in anatomical observation in the first trimester is associated with a great reduction in maternal anxiety. So, final comments. I believe that the evidence should be considered an opportunity. We are ready to perform scan weights for anything, and I believe that the anomalies should start in this scan because screening program that starts at 12 weeks and continues later is superior to one that starts only at 20 weeks. I believe it's no longer can we detect anomalies in the first trimester because we can and actually we can detect a lot of the severe ones. And then the question is whether we can justify delay diagnosis, because an anomaly detected early is a family empowered time and options. Thank you.
César, you are champion of exactly on time. I've never seen this exactly 11 minutes you finished. Thank you very much.
Thank you.
Quite extensive explanation about the pro arguments for first trimester scanning. Also, a little bit cheating and changing the statement. I will give more now to Dr. Meller. Grace arguing against.
Hi everyone. Well done, César. I have my word out for me, not only because of the poll, but also because of your amazing time management. I'm very impressed. Let's see here. I don't have any financial conflicts of interest, but I do have one important bias, and that is, like everyone here, I also perform and interpret detailed first trimester ultrasounds, and I could make many arguments for the first trimester ultrasound. I think the question is not whether or not the first trimester anomaly scan is valuable. It absolutely is. The question is whether or not it should replace the second trimester anomaly scan as a standard examination. And so my argument in this debate takes the question quite literally about whether or not we should replace it. Yes.
Can you please share your slides? We see you here. Now we see your slides. Thank you very much.
Sorry. Yeah. So the question is not whether or not the first trimester anomaly scan is valuable. It absolutely is. The question is whether it should replace the second trimester anomaly scan as the standard examination. And I think the answer is no. Great. So I think it's important to revisit the purpose of the anomaly scan. Obviously, as we're debating here, the primary goal is to detect structural anomalies and genetic syndromes. But the second trimester scan has lots of other value, including assessing cervical length, confirming the number and presentation and viability, although that can be done in the first trimester. I think a second trimester scan can enable optimal perinatal management. It can also inform reproductive choice. It can evaluate the AFI, which we can't do in the first trimester. It can assess placental location. And it can also confirm gestational age, which also obviously can be done in the first trimester as well. But there's a reason why there's international consensus among guidelines that that the second trimester anomaly scan is the standard of care, right? The American College of OBGYN still recommends that the anatomy scan be performed between 18 and 22 weeks. The same is true for consensus statement between the Society for Maternal Fetal Medicine and AIUM. ISHUOG says the same thing, that the 18 to 22 week scan remains the standard of care for fetal anatomical evaluation The Royal College, the Canadian Society all agree on this. And the question is, why have they not changed their recommendation to move the anatomic survey to the first trimester? And I think it comes down to screening. So I trained at the University of North Carolina in Chapel Hill, and I was lucky enough to spend part of my training with David Grimes, who with Ken Schultz in the early 2000s wrote a series of articles about epidemiology in the Lancet. And I've often referenced this paper on the uses and abuses of screening tests. And ultimately, the benefits of screening must outweigh the harms. And so I think about questions around the anomaly scan as a question of screening, especially when it comes to population level. So screening, as you will know, is the testing of apparently well people to find those at increased risk of having a disease. But screening can improve health, but it can be expensive, it can be inconvenient, it can be unpleasant, and it can lead to unnecessary intervention or harmful treatment. And as you know, screening is a function of the detection rate, the positive predictive value, the sensitivity, and the specificity of the test that you're performing. And so why haven't the major societies moved this recommendation to move the anomaly screen from the second trimester to the first trimester? And I think largely it comes down to detection rates, right? So this is not a comprehensive list of all the studies that have ever been done on second trimester screening, but most contemporary studies are going to report sensitivities or detection rates in the 30 to 50% range. And so the Cochrane review from 2024 reports a 50.5% sensitivity for structural anomalies before 24 weeks. The highest detection rate on this slide is going to be the Celio study, which looks at a lot of babies, but ultimately that's at a referral center with specialized expertise. And so this is not going to be applicable to population-based screening. And the authors explicitly say that their performance is only achievable 20 years after the Eurofetus study with trained operators. And so I think when we ask questions about if we're going to move the anomaly scan from the second trimester to the first trimester, we're going to have to ask questions about whether or not we can achieve this on a population level, not in fetal centers. The other thing I want to point out is that detection of fetal anomalies in the second trimester is really a function of the condition that we're searching for, right? So it's relatively easy to identify bilateral renal agenesis. It's more complicated to identify congenital diaphragmatic hernias. And so when we're talking about detection rates, I think it's important that we talk about the condition that the screening and detections are a function of the actual anomaly that we're looking for. And in the first trimester, many anomalies just aren't visible yet, right? One of the biggest misconceptions I think about this debate is that because we have great technology, because technology has improved, we can just simply move the anomaly scan earlier. But that's not the fundamental limitation. I believe that the limitation is developmental biology, right? So take agenesis of the corpus callosum. It doesn't become fully visible until the second trimester. The same is true for gastrointestinal obstructions, duodenal atresia, jejunal atresia, and other obstructive lesions often don't produce dilated bowel or poly well into the second trimester. Ventriculomegaly is the same thing. And as we know, we can see amazing things. I had a similar clip to you as Monique, right? Of a 4-chamber and 3-vessel trachea view in the first trimester. I see that all the time and I'm amazed. But I don't feel confident, even though I do these scans regularly, making a confident diagnosis of congenital heart disease without a later scan. And so I believe that developmental biology, not technology, is the real limitation here. We can talk a little bit about the performance of first trimester anomaly scans, and all of these studies are going to show that there's a less detection rate. The one thing I will point out is that in the last study, the overall detection rate is 27%, but it's frequently cited and frequently quoted, but it reflects major structural anomalies in an expert fetal medicine center using a standardized protocol. This is not the expected detection rate in routine population screening. And so I think that remains a problem. And so I would point out that implementation, not innovation, is the limitation here, right? Even Ishwag basically says the same thing, right? So Ishwag basically says that the performance of first trimester anatomical assessment is highly dependent on operator expertise, equipment, and adherence to standardized protocols. It specifically requires expertise, standardized protocols, and quality assurance. And I ask, if health systems across the globe can consistently perform this level of pregnancy, I mean, this level of quality for every pregnancy. And I just don't think we're there yet. So implementation, not innovation, right? Studies that are published are performed by highly trained operators using modern ultrasound equipment. They follow standardized imaging protocols. They undergo continuous quality assurance. But population screening is judged by what is reproducible, right? So most pregnant people receive care in the community, and operator experience is going to be highly variable. Exam times are probably shorter. And this, I don't imagine that quality assurance programs are very consistent. And access to tertiary expertise isn't universal. So the question isn't whether or not all of our amazing fetal centers can perform first trimester anatomy scans. The question is whether community obstetric practices can. So what would a community obstetrician tell a patient after a possibly abnormal first trimester anomaly scan? I don't think that most would recommend abortion care around that exam alone. Most will order another ultrasound, and most will refer to a fetal center. So before replacing the second trimester anomaly scan, a first trimester scan would need to detect at least as many anomalies, which it can't do, produce fewer false positives, which it's not likely to do, be feasible, and be reproducible. And I would just argue that replacing the second trimester with the first trimester scan doesn't do any of these things yet. So I go back to Grimes, right? I say that screening is he says that screening is a double-edged sword. An inappropriate application or interpretation of screening tests can rob people of their perceived health, initiate harmful diagnostic testing, and squander healthcare resources. So in closing, the first trimester anomaly scan is valuable. I don't debate that at all. I think it's an important part of care, and I think we're ultimately going to all agree on the same points. I'm just being quite aggressive on the against for the sake of the debate. We should expand the performance of the first trimester anomaly scan, but I do not believe that the evidence supports replacing the second trimester anomaly scan, nor do I actually think that on a global scale that we're ready to do that. And so I think I support expansion, but I do not support the replacement of it. And since I have 1 minute and 39 seconds left, I'm going to soften my position just a little bit and go to this question of compromise, right? Because I think it was brought up earlier, and it will facilitate an interesting conversation between us. I think that the evidence supports two complementary examinations, not replacement. And I think that I'm going to bring up the same study that you did, César. This is a Cochrane meta-analysis of a hypothetical cohort of 100,000 pregnancies. So these aren't real world numbers, but I think it's a really interesting illustration that when you look at first trimester alone, they predict a detection rate of 37.5%. And when you look at second trimester alone, they predict a detection rate of 50.5%. But when you combine the two, we're talking 83.8% with a false positive rate. When you combine the two, that is lower overall. And so I think the future is not replacement necessarily, but expansion of the first trimester ultrasound and probably some combination of both. And I'll go back to my thank you slide.
So quite a strong argument against. And if we look back to the title of the debate, the anomaly scan should be moved to the first trimester. You can explain the wording the way you want, but I think both competitors had quite strong arguments. I would like to invite all the people in the audience to put some questions or remarks in the chat function or in the question function, because we do not see many questions yet. The first question is that the statement is a bit misleading. Jose Carlos Ferreira says it is misleading. Many would disagree with changing the anomaly scan from the second to the first, and I think we all do agree with that. Some things I find very interesting in your debates was, especially because I'm from a very small country, the effect of distance to fetal medicine departments, and also the arguments you both stated on combining, so to increase the total detection rate. That was a perspective that was a bit new for me. Can you both comment on that?
Yeah, I believe that actually we are on the same side. I agree on not replacing the second trimester scan, but increasing detection rates and the possibility of decision making when you have some problem detected early, you have more time. And again, in countries like mine, I'm sure like so many others, distances are important, but also healthcare insurance problems are really a problem, and people may lose the opportunity of taking or making reproductive decisions just because of problems with the availability of I don't know, a CVS, or the availability of referrals to another center, or the availability of getting in time for a fetal therapy. So I believe that integrating first and second trimester will lead to better options for the parents.
Matt,
I
can
think
you
that
comment on that as well?
Of course. I mean, I think it comes down to, again, some of the principles of screening. And one of the questions I always ask myself that Grimes taught me to ask was like, if you're going to do a screening test, you need to have a follow-up, right? You need to, like, you can't screen for a condition that you can't treat. And treatment doesn't necessarily have to mean in utero therapy. It could be pregnancy termination, or it could be perinatal management, right? And so the other thing I think about in terms of positive predictive value is the incidence in the population that you're screening, right? So how prevalent a condition is in your population will dramatically influence your positive predictive value. And so what we have employed, both from a resource standpoint, but from a screening perspective, is doing detailed anatomic surveys in the first trimester for patients at high risk of, so that the incidence is higher and the positive predictive value is higher. So we don't have the capacity to offer first trimester anatomy screening to every patient within our healthcare system. But what we do have the capacity to do is offer it to patients who are at high risk, either because they had an anomaly in a prior pregnancy, have an abnormal cell-free DNA screening in the first trimester, or had a prior pregnancy affected by an anomaly or genetic syndrome, and a couple of other conditions, pre-existing diabetes and other things that bring their a priori risk of having a detectable first trimester anomaly higher, so that our sensitivity, so that our positive predictive value is higher. And so we just don't have the capacity in the United States, or even within the healthcare system I work, to offer detailed anatomic survey to everybody. But I think it is a question worth asking. And I think that expanding it probably to a high risk population is probably the right strategy for now.
And also a remark and a question from Tim van Mieghem. I think it's quite also an interesting thought, especially also with high BMI in the back of our minds. And he says, how about doing a first trimester scan and a third trimester scan, skipping the 20 weeks anatomy scan? Would that not yield the highest cost benefit ratio?
I mean, it probably would. I think it would remove some choice. I mean, it would remove some of the aspect of reproductive choice for some families in that situation. I think it would also remove the possibility of in utero intervention for certain conditions. It's a provocative question.
Yes, César?
Yeah, I think the success of modern screening comes from moving diagnosis forward, not from removing opportunities. I think that we need the first, the second, and the third trimester scan, and use them as an opportunity to detect as much as we can. Even with the first and second and third trimester, there are some things that are going to be missed. Detection rate will not be 100%. But I believe that it's a matter of not removing opportunities, but increasing the chance of detecting problems.
A strong argument against first trimester scanning, and Rosemary Rice is stating that, is the false positives. And if we look, some of the IMITAS data has brought forward by César, and I think the old false positive rates are not really true. So can you comment on false positives?
I believe that as any screening, we will have false positive results, but as I've shown in the presentation, maybe similar to the second trimester scan. And I agree with Matt. The important thing is not because we have to accept false positive result. The important thing is that you need to know what you are going to do next with the positive result to discriminate if it's a positive or true false positive or a true positive result. You have to know in any screening what you're going to do next, the next steps. You have to have a referral center if you are not a fetal medicine specialist. You have to know what you're going to do next. Proper counseling and avoid, for example, termination of pregnancy without proper counseling and without being sure what's going on. So I'm not worried.
That is not fully in your hands. If people would not choose to terminate because of uncertain findings, or Matt, can you comment on that?
Yeah, I mean, I think this situation is not uncommon, right? For those of us that do detailed anatomic surveys in the first trimester, kind of following ISHUOG or AIUM guidelines for that, because you'll get 90-something images of a first trimester fetus, and your sonographer will come to you and say, at least mine will, and say, I don't think the heart looks right. But what do I do with that information, right? And I take very seriously the responsibility to concern a family, to speak with a pregnant person and say, I'm worried about your baby's heart, but I can't tell you exactly if there's something wrong with it or what exactly is wrong with it. And so I think that it's one thing to report false positives in the literature. I think it's another thing to sit with a family and to try to help them understand that there might be something different, but I can't really say. And again, I think that's the value right now, at least in the system that I work in, to offering this to patients where the a priori risk of there being something abnormal is high. I mean, obviously, every patient in my healthcare system in the United States should get a routine first trimester ultrasound, but that's not an anatomic survey, right? That is crown rump length, limbs, and just some basic, first trimester measurements. But hopefully a sonographer that has some experience and whoever's interpreting those images will notice an acrania, or will notice, I guess I would say omphalocele, but that could just be bowel herniation. But some of the big things that we're trying to detect with an anomaly study, as we're describing it, should be detected in a routine, what we call, at least in the States, a first trimester ultrasound, which only has very limited views, but an astute sonographer should catch some of those things. So, but yeah, I think false positives is a real concern. And I think that's both, something that's discussed in the literature, but I think the lived reality of it is much, much more challenging, because you're right, Monique, patients will hear me say, there could be something wrong, but I'm not sure, and immediately just make decisions to not continue their pregnancy.
I agree, but we also have false positive results with the NT for screen for trisomy 21, or actually with the NIPT. And we know what to do. And perhaps in 7, 10, 2 weeks, the time that it takes to have an amnio and the result, you may have the answer. And the same happens here. In the IMITA study, they showed that between the suspicion and the final diagnosis, it was around 13, 14 days, let's say 2 weeks. So we also accept false positive results in the, NT, 3 to 5%. And you say, okay, let's do a CBS or an amnio, and results are going to be, it depends on the system, but 7, 10 days later. The same happens with this. We can do another scan with a bigger baby, and perhaps the real decision, it's normal or not, it's 2 weeks later. So I believe that it's worth including it as part of it, not replacing the second trimester.
And then a final comment is in how early ultrasound relates to NIPT, if we have to do before or after, and if it is valuable. There are some systems that have standard offer of NIPT. Is a first trimester ultrasound then still necessary, or should we do it after NIPT?
Oh, I think a first trimester scan is necessary. And I think my good friend Neetha Vora, who has been around in ISPD for a long time, published a paper early in the days of cell-free DNA that talked about other things, that how an early ultrasound sometimes changes the plan to do NIPT, right? So if we see something, then we're going to skip NIPT and go straight to diagnostic testing. And so, or a vanishing twin that might cause false positives. So I think there's value to it before. And ultimately, we do detailed first trimester scans on patients who have abnormal cell-free DNA very, very frequently. And during that visit, offer them diagnostic testing, in-person genetic counseling, and a diagnostic CVS if that's something they want the same day. So that's the sequence of how we kind of do things in our system.
I think César agrees.
Yeah,
I think on that part, that was a comment of Renee Jones, and on that part, it also differs in the world very much how expensive NIPT is. In some systems, it's for free, and other systems, people have to pay €1,000. So that is that are big difference globally. I think what we all did not succeed on is to really disagree. But Pate is suggesting to do the poll again. Pate, please share the QR code. And there is a little bit of delay. The final poll, the anomaly scan should be moved to the first trimester. Please, dear audience, scan the QR code and let us know what you think and what your opinion is.
Is there a second poll where people can register who they're cheering for in the soccer match on Saturday? Since Argentina will be playing, I'm looking forward to that game.
Argentina against?
Switzerland.
Sweden,
my bad.
So we had before the presentations, we had 45% in the agree and 46 in the against. So now many people, now it's running. Now we are crossing the delay. So it looks now that Matt has gained some arguments. But now people are finding the buttons on their phones. We wait a little longer. But it looks like that Matt has gained a lot of votes. But at the end of the day, we were very much agreeing with each other. So maybe the football games are a better match than the statement of this debate. But at the end of the day, we had a very nice discussion, meeting the aims that I had in the first slide, explaining the audience that these debates are always so good to watch, because you have a detailed insight in both perspective and a very good wrap up of the current state of science on the statement. Yeah, I will close the poll now. Pate says in our chat. So Matt, congratulations, you have convinced the audience, but César, I think you also did very well. And I thank you both very much for preparing this debate and being present here. And it was nice getting to know you both, and also the audience for submitting their questions. And we will close this session. Thank you very much.
Thank you.
Thank you all.